Good evening, friends. It's 8 o'clock, and let us set the ball rolling. We have eminent faculty from across the country. Professor Subbiya sir is the professor and head of the Department of Surgical Oncology at Government Raipeta Hospital. This is one of the pioneering centers apart from the Cancer Institute at Chennai. They have a very long-standing, robust, very prestigious program, and it is one of the regional cancer centers, and it is part of the Institute of Non-Communicable Diseases Network of Tamil Nadu. Warm welcome, Subbiya sir, and he's been good friend, mentor, and then much liked by the students. So thank you for joining us today, sir. And we have Professor Mayank Gupta. He is the professor at the RCC Tata Memorial Center at Varanasi, Uttar Pradesh. So sir will be joining, just finishing up a flap procedure. He messaged me. So he'll be joining in 10 minutes time. Professor Deepak Rajput is still held up in AIIMS Rishikesh with some long procedures. I wish he could join, but only the postgraduate picked the phone. But let us wish others also join. So we have other eminent faculty, Professor Khanna sir, Ajay Khanna sir from Institute of Medical Sciences, Varanasi, who has kindly contributed Dr. Sudabrata Garai for today's presentation. Professor Karnakaran sir, Professor Sahai sir, and other senior professors who have joined today. The second candidate is Dr. Yoga Priya Velumani, again kindly contributed by Professor Amit Gupta from AIIMS Rishikesh. So the first case will be on obstructive jaundice and second case will be on soft tissue tumor. Friends, they both are malignancy cases. So we have invited the oncology team also to be part of us. So as you are well aware, the candidate will go presenting without any stop till the clinical history is over. Then the examiners revisit all the slides and then ask questions. And I request the examiners to give the answers if the candidate is finding difficult to answer, because it is in the teaching format we normally keep. So I wish, as an examiner, what will be the convincing answer you expect from the student if the student is not able to tell. And then we run through the management part of it. Then initial part can be on the evaluation staging, and then later some recent advances also we can touch upon. So we have 1 hour for the first case and 1 hour for the second case. So I wish good luck to Sudabrata, and then
thank you, sir.
Faculty, please take over. Sudabrata, we are unable to see you. We are able to see your presentation. You have to switch on your video. You'll re-log in. You have any challenges, Mark?
Yes, sir.
I wish others except faculty and the presenter, please keep your mind in mute position, because this is I don't want any disturbance for the faculty here and the candidates who are presenting. Humble request, all the students and the participants here, please switch off your mic carefully, because the presenting students and the faculty takes precedence here. Warm welcome to Jailal sir, Rajgopal sir. Thank you for joining this evening. So we look forward for active discussion today. So Sudabrata, good luck to you. So
thank you,
please
sir.
share your PowerPoint, introduce yourself, your unit chief, head of the department, and start your presentation.
Myself, Sudabrata Garai, from junior resident from Department of General Surgery, IMS BHU. My moderator is Professor Ajay Khanna sir, and my head of the department is Professor Seema Khanna ma'am. Should I start, sir?
Please go ahead, Ma. Good luck. You are fine. Good to go. Faculty will care, ask questions. Keep going till the summarization of the history part of it.
Okay, sir.
Abhay sir, good evening, sir.
36-year gentleman, resident of Mau, Uttar Pradesh, a carpenter by occupation, came to OPD with chief complaints of pain in right upper abdomen since last 6 months, along with dyspepsia since last 6 months, and he also complained of yellowish discoloration of eyes and urine since last 8 days. He was apparently asymptomatic until 6 months back, when he developed pain in right upper abdomen, which was insidious in onset, mild in intensity, dull aching, episodic, relieved spontaneously, and non-radiating. Patient also complained of dyspepsia for the past 6 months, which was insidious in onset, gradually progressive, and relieved on medications. He also complained of useless discoloration of eyes and urine since the last 8 days, which was insidious in onset, gradually progressive, and not associated with itching or clay-colored stool. It was associated with nausea and loss of appetite. There was no history of fever, vomiting, abdominal distension, altered bowel habits, hematemesis, melena, loss of weight, and chronic drug intake. Patient has no known comorbidities, and there is no history of any ATT intake. There is no history of any surgical intervention in the past, and there is no history of any repeated blood transfusions. There is no history of similar illness in the family members. There is no history of cancer-related death in the family. Patient takes mixed diet, and his appetite is currently decreased. Patient has normal bowel and bladder habits, normal sleep-wake cycle. There is no history of any allergy, and there is no history of any addictions. To summarize, my patient, 36-year gentleman, presented with pain in right upper abdomen since last 6 months. He also complained of dyspepsia for past 6 months, along with yellowish discoloration of yes, along with yellowish discoloration of eyes and urine since last 8 days, which was not associated with itching or clay-colored stool. He also complained of nausea and loss of appetite.
No.
In general,
hang on,
yes,
Dr. Garai. So what do you
Please
think
go
is
to the
your
first slide.
diagnosis? What do you think is your diagnosis by history? What are you dealing with?
so this is a case of jaundiced patient, probably due to obstruction in the obstructive jaundice, surgical jaundice, and probably due to malignant etiologies.
Okay. So why do you say it's obstructive jaundice by your history?
Sir, patient has pain, progressive jaundice for the last 8 days, but in this patient, there was no associated itching or clay-colored stool or other features of obstructive jaundice.
No, it's not clay-colored. It is pale stool. Okay, don't say clay-colored.
Yes, sir.
It's pale stool. Okay. So just jaundice in 8 days with pain and dyspepsia for 6 months. How can you reach this thing of surgical jaundice? Anyway, what is surgical jaundice? You tell me what is surgical jaundice?
Generally, we term the post-hepatic jaundice, which can be due to obstruction at various levels, as surgical jaundice.
No.
After ruling out medical cause.
Only jaundice, all jaundice which can only be treated by surgery is called surgical jaundice. It's SOJ, surgically obstructive jaundice. Okay? It doesn't matter where it is. Okay, so why do you think it's obstructive jaundice, first of all? And then we'll come to malignancy.
Sir, patient was complaining of there was gradual progression of jaundice in the son's since the last
8 days of jaundice, progressive jaundice. How do you get in the history in 8 days? Is progressed from what, nil to very deep jaundice?
The patient was initially not jaundiced, and he rapidly had progressive jaundice since in 1 week.
8 days. Look, Dr. Garai. 8 days of jaundice increasing. How much will it increase? It can't increase from 2 to 15. Has it? Has it become very deep jaundice?
Patient, sir, when he was admitted,
how could you take in your history that is progressive jaundice for 8 days? What did he ask?
Sir, according to patient's version, sir, there was gradual deepening of the urine and
Let's go to your first slide. Let's go to your first slide.
Yes.
Okay, next slide. What do you mean by episodic pain? What do you mean by episodic pain?
It occurred that it did not have a continuous pain. It has had at intermittent at some intervals.
So, you know what is episodic pain?
Yes, a patient does not have continuous
No.
continuous
Episode
pain.
means what? Episode means a story. Something which is not documented is episodic.
Yes, sir.
But say intermittent, say intermittent rather than episodic. It's not episodic. Episodic
Okay,
means
sir.
someone says, right?
Yes, sir.
Non-radiating, mild intensity, dull aching. So, okay, next slide. What are the aggravating and relieving factors for this pain?
Sir, along with food intake and
So write
any
it out. Write
addiction.
it out. Write it out. Any vomiting?
Sir, no history of there was vomitings. Yes, sir.
Okay. Okay. So please. Okay. So no one asking.
No, doctor, what is your name? Sudha.
Yes, sir.
Dr.
Sudha
Bharat.
Brothers.
Yeah.
Sudha.
Yeah. What is the dyspepsia? What do you mean by that? 6 months patient had a problem, no?
So
You
patient had complained of intermittent indigestion because he
What
complained
exactly?
of
Yeah, correct. What is it? What do you mean by that? See, this patient's complaint is dyspepsia and then last 8 days jaundice, correct?
yes, sir.
Correct. So if you keep that in mind, you also written
Yes.
that patient has loss of appetite. And you have written
Yes, sir.
dyspepsia started first, correct?
Yes, sir. Dyspepsia was initially started. Yes,
Now you started telling indigestion.
yes, sir.
What do you mean by that? What do you mean by dyspepsia? What do you mean by dyspepsia? It's some kind of a
Dyspepsia.
broader. Yeah, please go ahead.
So dyspepsia can be from the altered, sir, regular from the after taking food, he complained of not proper mild abdominal distension and flatulence, and there was no proper digestion, sir.
Correct. So more than digestion, you have to refer it to upper abdominal discomfort like burning, bloating, gaseous flatulence.
Yes,
So they are typical of what kind of a diseases generally? Is it
so it is
peptic
characteristic
ulcer?
of
Is it peptic ulcer disease it suggests, or is it suggest probably a gallbladder pathology, or is it due to the fatty food intolerance? See, this is what is important for in your case, particularly case, correct?
yes, sir.
Why is that?
So in this case, this can be probably due to gallbladder pathologies.
So what I'm trying to give you, the clue is that when you have a patient has this kind of a complaint, you have to find out, is it related to gallbladder? Is it related to
Yes, sir.
pancreas, or is
Yes,
it
sir.
related to stomach?
Yes, sir.
So do you think I'm just putting just straight a question to you? Do you think it's probably the problem is in the stomach and then it will cause some problems like this? Do you think it's stomach problem? Stomach, when I state, okay, carcinoma stomach, I'll ask you this question.
Sir, if we think of, sir, any stomach pathology, sir, along with that, there will be any carcinoma stomach or gastric outlet obstruction. There can be anorexia, and along with anemia and other symptoms.
So
sir.
what that is the presentation you are talking. What I want you to understand is, here is a patient who has got a dyspepsia for 6 months. What do you mean by gradual progression? There you should mention. Prelude on medication means what type of medication? So early satiety. So if this is associated with the early satiety,
Yes, sir.
early satiety and significant loss of appetite and weight loss, that can come together to say that you are
Yes, sir.
ruling out carcinoma stomach. What do you mean by early satiety?
Sir, the early satiety is after taking the meals, there is very quick postprandial fullness, and patients have they don't have to take further meals.
No, not that don't have to. What it means, he says he can't take further because
He can't take further meals, sir.
Because that receptive relaxation property of the stomach itself is lost. There's some
Yes, sir.
friction there. So you
Yes,
are to indirectly rule out like this. So biliary tract is one. So pancreas, when you
Yes,
talk
sir.
about indigestion, steatorrhea, then we
Yes, sir.
give more importance to the pancreas, chronic pancreatitis, etc. Okay, right? So,
Yes, sir.
yeah, how severe is the itching? Because
So there was
There's no itching.
characteristically in this patient, there was no complaint of itching, sir.
so that is the one question I wanted to ask you, because in what basis you say patient has obstructive jaundice?
Sir,
You said this is a case of obstructive
yes, sir.
jaundice. I will tell, let us say it is not a case of obstructive jaundice. What is your answer for that?
Sir,
You
from
were-
history, we cannot properly infer that it's a case of obstructive jaundice.
Then why
Uh,
did you say that? You understood the question?
Sorry, sir.
In MS,
Yes,
not
sir.
sorry. What I'm trying to tell is, in MS examination, you have to say first of all why this patient has got a jaundice. That is very clear, correct? Yellow
Yes,
discolored
sir.
eyes and urine. Second question
Yes, sir.
commonly asked is why obstructive? Why obstructive?
Yes, sir.
In the absence of clay colored stones, whatever you written there, altered colored stones, and then
Yes, sir.
itching. So why did you say it's obstructive? Suppose I ask you why not it's a hepatocellular jaundice? What answer you will give?
Sir, if it is a hepatocellular jaundice, the duration is quite significant for 6 months, and there is sudden appearance of jaundice in the last 1 week. And
You said it is only 8 days, correct? 8 days.
yes, sir.
He may be having a viral hepatitis. I don't know. I'm just asking you. He has got a nausea. He's got loss of appetite, correct?
Yes, sir.
So just you have to keep it mind open. So he has a patient has a dyspepsia, which is progressive. Dyspepsia progression means what? Weight loss, I can understand. 5 kg, 10 kg, 15 kg. So is he able to eat at all or not able to eat at all?
Sir, initially he was not taking medications, so he was having gradual problems day by day. But after taking medications, it was relieved. So in his own terms, it was said that it was progressive.
All right. Yeah, next slide. Just I'll take 1 or 2 questions, then I will. Yeah, so here you are written there, no loss of weight or nothing.
Sir, yes, sir. No loss of weight, sir.
Then why did you still thinking in terms of malignant jaundice? That's what you said, no? Correct?
Yes, sir.
You said first is obstructive jaundice, second one is malignancy, correct?
Yes, sir.
Why did you ask that question? Abdominal distension.
Sir,
abdominal distension.
say abdominal distension, if there is a mass, if there is a periampullary carcinoma of the stomach, of the periampullary carcinoma, and it can produce duodenal obstruction causing abdominal distension, sir.
You won't have to go to that level of abdominal distension. In that, patients will have vomiting, carcinoma head current, but best is to say, ascites, no, simple. The common cause, ascites, fluid
Yes.
Yeah, I think I
Yes,
will, sir, some other examiners.
Dr. Garai, abdominal distension cannot be caused by periampullary carcinoma. It will obstruct the duodenum.
Yes, sir.
So the upper GI will not cause obstruction. That high will not cause abdominal distension. Also, right? Why in this case actually you're falling in trouble because you should say that there's no diagonal. Give a differential. And the first differential will be gallstones. Why not gallstones?
Yes, why not? Yes, correct.
Right? So
Yes.
you can't say it's malignant. You can't say it's obstructive jaundice by history.
Yes, sir.
You can just say that the patient is jaundiced with pain
Yes,
and
sir.
dyspepsia, come to surgery ward OPD. So it could be gallstones or CVD stones.
Yes, sir. CVD,
Right?
yes, sir.
Right. So that would be your first diagnosis. Second would be, like Sir said, it could be viral hepatitis.
Yes, sir.
Right? And then could be anything else.
Yes, sir.
But surely not malignancy in this case. Not as yet.
Yes, sir.
Right? So
what indirectly in your university examination, you will not the diagnosis and then try to read backwards. You understand, no?
Yes, sir.
Here you know that today you are presenting obstructive jaundice, so you are going to tell that. But remember, You have to try
Yes,
to
sir.
correlate all this. Correlate. Okay? Yes.
Yes.
That's all from my side.
We move to examination then.
Can he answer that? What is the point against choledocholithesis in history? From the history that you have given?
Yes, sir. Ma'am, there is no intermittent fever or intermittent pain or
That's okay. There are no features of cholangitis. One is that pain may be colicky, and then you said it's progressive jaundice.
yes,
So
ma'am.
usually patients with choledocholithesis may have
Yes.
variation in the level of jaundice also.
Yes, yes, ma'am.
Yeah.
Okay.
Jara, you are still in history taking stage, you know. So if I want to answer in your place, I'll answer that here is a patient who is having some sort of vague chronic abdominal symptoms recently superimposed by jaundice. That means with that level only you can think of. It is not acute. Number one, you said
sir.
it is 6 months.
Yes,
Number
sir.
one, it's not acute. Number two, it is not, the pathology is probably not from intraluminal pathology because jaundice is a late occurrence. If
Yes,
it
sir.
is intraluminal, jaundice should be the first occurrence. And
sir.
it is not infective because there is no signs and symptoms of cholangitis or viral hepatitis.
Yes, sir.
With this level, we should stop. Beyond this, you should not commit actually. If you commit cancer and all, you will be in trouble. You are having a patient who is having vague upper abdominal symptoms for 6 months. Now, for the past 8 days, he is presenting with jaundice. That means probably the jaundice is secondary to some other pathology rather than the pathology being secondary to jaundice. That level only we can conclude. Beyond that, we cannot conclude. General, good evening.
Yeah, good evening, sir. Okay, should we go to examination now?
Sir, patient was examined in a well-lit room after taking consent.
One second,
And-
man. I think we have Professor Subbiya sir and Dr. Mayank would like to ask any questions, sir. Yeah. Please go ahead.
Sir, patient was examined in a
Okay,
Yes.
okay. Please go ahead.
Sir, patient was examined in a well-lit room after taking consent. Patient was conscious, alert, cooperative, well-oriented to time, place, and person. There is no pallor, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. Icterus was present, and patient was moderately built. Height was 152 centimeter, weight was 70 kg, of BMI 24.3. Patient was afebrile, pulse rate was 70 per minute. Blood pressure was 130 by 70 millimeter of mercury, and respiratory rate was 16 per minute. In abdominal examination, on inspection, abdomen is normal in contour, and umbilicus is inverted, central in position. All quadrants are moving proportionately with respiration, and there is no visible swelling or dilated veins or visible pulsation or peristalsis. And the hernial sites were found to be intact. On palpation, the abdomen is soft and non-tender. An intra-abdominal lump of size approx 5 into 4 centimeter present in the right hypochondrium and right lumbar region, which was firm in consistency, non-tender, smooth surface, well-defined medial, lateral, and inferior border with slight side-to-side mobility and is moving with respiration. There was no hepatomegaly or any other organomegaly present. And renal angle tenderness was not present, and no other lump was palpable. On percussion, the dull note was present over the lump, which was continuous with the liver dullness, and liver span was noted to be 14 centimeter in the right anterior axillary line. On auscultation, normal bowel sounds were heard. On digital rectal examination, patient was found to have normal anal tone, no palpable mass or nodule. Fecal staining of gloved finger was seen. and no melena or blood stain was present. Supraclavicular lymph nodes were not palpable, and there was no stigmata of chronic liver disease present except jaundice. Systemic examination was found to be within normal limits. My patient summary to summarize, my patient, 36-year gentleman, presented with pain in right upper abdomen since last 6 months, along with dyspepsia for past 6 months. He also complained of jaundice since last 8 days, which was not associated with itching or clay-colored stool. He also complained of nausea and loss of appetite. On examination, the patient was having approx 5 into 4 centimeter palpable gallbladder lump in the right hypochondrium, extending up to right lumbar region, which was firm in consistency, smooth surface with palpable lateral, medial, and inferior border, and moving with respiration.
So, Dr. Gorai, in an obstructive jaundice, when you
Yes,
are
sir.
starting the examination, what is the first thing you are supposed to see in a patient? The patient walked in your OPD with obstructive jaundice. What is the first thing you will see in the patient? What is performance status of the patient? Have you noticed the
performance status.
performance?
Yes, sir.
Do you think it's important in this case?
Yes, sir. It is definitely important in this histories.
So in an obstructive jaundice patient, performance is what all it will give you, what all information it is going to
Sir, if there are
unveil for you.
features of any encephalopathy, it can detail the performance status of the patient.
Plus, first thing it will give you an fair idea what is the chronicity of the obstructive jaundice, right? Plus,
Yes, sir.
if patient is having a patient with obstructive jaundice, so cholangitis is one entity which not necessarily always present with, obvious fever and all. Patient may be unwell, not performing, not able to walk, and suddenly one day he will have severe cholangitis and collapse. So you have to be very careful while seeing this patient. Also, performance status give you a clue that is it a benign pathology or probably a malignant pathology. Plus,
yes,
what treatment you are going to offer. Suppose it's a malignancy, so will you offer a radical treatment? Not, because if the performance status is not good, probably you may not offer in a very radical treatment. So all that information you will just get it from performance status. So that is very important finding in a obstructive jaundice. Okay. So
yes.
how do you see performance status? Any scale you know of?
Sir, we know of the Karnofsky's performance score, sir.
Yeah, and another one is more commonly used is ECOG scale.
ECOG scale, sir. Yes.
Okay. And so, what is the why did you do digital rectal examination in an obstructive jaundice? What are you expecting?
Sir, if there is present complaint of melena, then we can find, sir, any fecal stain of melena present on the gloved fingers, any or any mass or growth palpable apart from the pathology of primary pathology, or any fresh
So do
pear
you
bleed or
think
something.
if a patient has a multiple liver mets, suppose liver
Yes, sir.
dysfunction, multiple liver mets, can he present with jaundice? I won't say obstructive, but he may present with jaundice, right? So even colorectal diseases which are known to grow liver mets. So
Yes, sir.
you have to see that is there any rectal growth that will be explained there.
Yes, sir.
Suppose it's a multiple liver mets that may also cause jaundice. Okay, because of
Yes,
liver
sir.
dysfunction. So probably that is the importance of doing a DRE in this patient. And okay, okay.
How confident you are patient having no pallor when the patient is jaundice?
Sir, patient was not found to be having features of anemia. Sir, there's no paleness in the lower palpebral conjunctiva, in the tongue, on the palms, and the undersurface of the
Not
soles.
see on the eye, but you can see on other areas. And that also
Yes,
is
sir.
difficult. When you confidently say it is no pallor, when there is a extensive jaundice is there, you will not be able to make a very strong statement.
Yes, sir.
Okay, Subrata.
Yes, sir.
Next slide, please.
You are not talked about his hydration.
Yes, the patient was adequately, sir, hydrated, sir.
Why is hydration important here?
Sir, there can be features of hypovolemia, and
Why?
patient can be dehydrated.
Why? That's what I'm asking. Why should the patient be hypovolemic? He's not vomiting.
Sir, if there are features of cholangitis and along with vomiting, sir,
If
patient,
I'm talking about your patient,
yes, sir.
you think your patient is, you said is he dehydrated?
The patient was adequately hydrated, sir.
So why is hydration important then?
Sir, hydration can be if the patient has a malignant pathology or any other symptoms, then they can be hydration can be impaired, sir.
Look, Dr. Gurai, get rid of this malignancy as yet. We've got nothing to prove that your patient is a case of malignant obstructive jaundice. Okay?
Yes, sir.
Why do you think it's malignant obstructive jaundice from your examination also? You've got no ascites, you've got liver span is 14 centimeters, mid anti-axial line, which is now should be mid-clavicular line. Nothing to no lymph nodes, nothing. Why do you think it's obstructive jaundice malignant?
Sir, patient has palpable gallbladder, and
So,
along with,
what are the causes of palpable gallbladder?
sir, it can be due to benign causes, along and also malignant causes. So,
Okay, tell me that.
in benign causes, we can think of, sir, mucocele or empyema, or, sir, any cholecystolithiasis.
Okay.
Define Courvoisier's law. You have a patient
Yes,
with
ma'am.
jaundice with a palpable gallbladder. This is what
Yes,
Dr.
ma'am.
Sahai is leading you to.
Ma'am, it can be due to
What
benign
is
pathologies like,
Courvoisier's law?
ma'am, in a patient of jaundice, the gallbladder is seldom palpable due to cholecystolithiasis or gallstone disease.
In a patient of jaundice, if the gallbladder is palpable, it is seldom due to stones, right?
Cholecystolithiasis
So,
yes.
Why?
so in your patient, what is the depth of jaundice? Is the patient deeply jaundiced or there's mild icterus?
When patient presented initially, he was not deeply jaundiced, but after within a
When you
span of
examined
week,
him, when you examined him, was he deeply jaundiced?
in last week only we examined him and he was deeply jaundiced. There was rapid progression of jaundice.
So what do you mean he was deeply jaundiced? What was the color of sclera?
Yellowish sclera.
Okay, can you grade the color of jaundice? Grade jaundice by the color of sclera?
If it is deep orange, we can say deeply jaundiced.
So this is where hydration also comes here. If the patient is inadequately hydrated, the urine would be dark enough to throw you off track, wouldn't it?
Yes, sir.
If the patient hydration is not adequate, what complication he can go for? Can it precipitate anything? Can it precipitate anything?
Sir, it can precipitate, sir, any hepatorenal syndrome or hepatorenal basically.
What are the other factors stimulate hepatorenal syndrome? One is dehydration.
Any infections, or any acid metabolic acidosis. any pathology causing metabolic acidosis.
Toxic effects of bilirubin, bile acids, decreased
Yes,
fibrinogen, all will lead to the ischemia and you get to the hepatorenal syndrome. So, in a patient obstructive jaundice, and you must be consciously looking for whether he is adequately hydrated. If he is hydrated, it is well and good. If not, that you should be take care that volume is maintained.
Yes, sir.
Dr. Gara, it's a good practice to mention all that liver related, you have actually later, after the examination of the abdomen, you have made one sentence there, no signs
Yes,
of
sir.
hepatocellular, something you have written there, correct?
Yes, sir.
Last, yes.
Yes, sir.
And see, you have written there supraclavicular node, and then you have moved to no stigmata of chronic liver disease except. So that should.
Is that Rajagopal Sanai sir? Is that a good word to say stigmata?
I don't know why you don't know, sir. Okay. Don't say that no stigmata and all that. It's not a stigma, man. It's like earlier used to tell, syphilitic stigma, stigmata. By one
Yes,
look
sir.
of the or leprosy, for example, they used to tell, nose, little bit of bridge collapse and other things. But I don't know, sir. I don't know why he has mentioned that. Because
they call it stigmata of liver disease usually because of alcoholism, and that has a poor negative connotation.
then what I wanted is only, sir, it should be in general physical examination at
Yes.
one stage.
It should come right in the beginning.
Because it's better, so that when you start examining the patient, okay, patient has bradycardia, or that you have written that pulse rate is normal. What way febrile you have written? Afebrile. Why it is important? Afebrile.
Sir, if there are features of cholangitis present, patient can be febrile if there is infection.
So it's very, very important, in your patient, especially if the dehydration,
Yes, sir.
febrile, you are going to ask for
Yes, sir.
some investigations. You are going
Yes,
to
sir.
get some CT scan. So lots of things can be precipitated, renal failure,
Yes.
etc. So that's what so it's better that you mention that here only, that, signs of liver cell failure or, chronic liver disease. Science is more than enough rather than mentioning, stigmata.
Better science is important.
Better to mention that. Just show that abdominal finding, that one slide. Yeah, that's true. So next, that gallbladder picture is there. Yeah, that is one. So why not? It's a part of the liver. I'm just asking you.
Yes, sir. Sir, the mass was globular in shape.
In other words, you answer why it is gallbladder. Why do you say it is gallbladder? Why it is not pancreas? Why it is not stomach? Why it is not liver? Why it is not retroperitoneum? Why it is gallbladder? That is what Sir is asking. You tell the findings which prompted you to say that it is a enlarged gallbladder.
Most of things you have written, doctor. So most of things are there, but just to confirm.
Sir, it was a globular lump, firm in consistency in the right hypochondrium, and the medial, lateral, and inferior borders were separately calculated.
Right hypochondrium means anterior line, mid-axillary line, mid-clavicular line.
Sir, it extends along the mid-clavicular.
No, Dr. Subrat, it's better to say right upper quadrant. Okay, that covers everything. Better to say that.
And the lump had slight side-to-side mobility, and it was moving with respiration.
Tender or non-tender?
The lump was non-tender.
So one important point you should remember is this mass or whatever you are seeing, is it seen or is it palpated or it is both?
Sir, only palpated, not seen, sir.
Very thin patients, in fact, it is better seen also because
sir,
it's an
patient,
when it gets enlarged, it almost comes very superficial, abdominal, just under the abdominal wall. Okay.
Yes, sir.
That is why when it's enlarged like this, You can sometimes skin patients, you can really see. But your skin texture of this patient also, if you see carefully, that doesn't seem to be having any jaundice. Actually speaking.
Yeah, that is what looks like a normal abdomen.
Most of us have got the experience of looking at one look. Anyway, we have to accept that. Not that we will not believe you, we'll believe you. But if you look at carefully, even the skin, there is nothing, no tinge at all. No, correct? Okay. Yeah. So you told about that. Why not? It's a. Why did you look at the consistency form? Suppose if it's hard or something.
Sir, if it is hard, then we can. If it is firm, then we can think of certain benign pathologies, and if it is hard, then we can think of malignant pathologies.
Like what? Like,
so if it is firm, so if it is soft to firm, or then we can think of it can be a mucocele, or it can be an empyema gallbladder.
Intra-abdominal, intraperitoneal, tense, cystic swellings like gallbladder, or they do not feel cystic, soft. Okay, most of them feel firm only, consistent.
Yes, sir, firm.
So hard, what I wanted is, will not be so big one, could be carcinoma gallbladder. Okay.
Yes, sir.
That's another possibility.
Yes, sir.
Any ascites you have mentioned, percussion wise?
No,
Percussion. Because
Sir,
you are not mentioned.
no free fluid. Yes,
where you are written? I can't.
Not mentioned.
So it's important.
It was
only mention about liver dullness and
yes,
the lump. But what is important also is always make a practice to, ascites has to be mentioned there. Okay. You have to mention.
Yes.
That is important.
Why is ascites important? Dr. Garai, why is ascites important?
So ascites in a patient of jaundice, if you're thinking of obstructive jaundice, then it can be signs of inoperability, sir.
Okay. And what? Why do you think it's a sign of inoperability? Why should the patient of jaundice of obstructive be inoperable?
Sir, if it is ascites, then we first we should and along with jaundice, then we should first.
Okay, tell me what are the causes of ascites in a jaundice patient?
Sir, in a jaundice patient, it can be due to tuberculosis, or any
jaundice
lymphomas,
patient tuberculosis. No, jaundice patient tuberculosis, where pulmonary tuberculosis with jaundice will have ascites.
Sir, any abdominal.
Why you are going for a far-fetched things?
What are the common cause of? You see patients with jaundice with ascites. Tell me the common causes.
Sir, if you're a patient of jaundice with ascites, then it can be due to malignancy, sir.
Straight away malignancy. What are the other causes?
Think of medical problems. No? First, why don't forget? No, first.
Will not cause cirrhosis. Will not cause
in cirrhosis of liver. In medical causes.
Medical causes you'll think of, no? There'll be
cirrhosis of
hyperproteinemia.
liver, then we can find. Sir.
Yeah, the liver is not functioning properly, right? There can be portal hypertension, right?
Yes, sir.
You see, think of benign, more common causes, right? Even viral hepatitis can lead to some amount of ascites at times. Malignancy is one of the. It's not so common. Even his age, he's 36, and what sort of malignancy would you think at age of 6? Obstructive jaundice. What is the normal?
Garai, if you are asked to say the reasons for ascites, then in your mind you should think that whether it is benign, whether it is malignant, whether it is transudate, whether it is exudate. You think like that, then answer. Here you are having a patient. Here you are having a patient with upper abdominal symptoms. No, and always you talk pertaining to your patient. Otherwise, you will be landing in trouble. Okay. Otherwise, you'll be landing in trouble. Here, your patient is having upper abdominal symptoms, and he is having a globular mass. You committed gallbladder. And when the examiner is asking about ascites, why do you jump to tuberculosis? The common thing in this scenario is either it is because of liver cell failure or it is because of malignancy. One of the two, You should not think beyond this. Can you say renal failure? Can you say cardiac failure? That also can cause ascites.
Yes, sir.
So you should think pertaining to your patient. Otherwise, the entire range of discussion will happen. You will be in big trouble. Okay. Thank you. Thank you.
You think it is a gallbladder is distended or gallbladder mass is there?
Sir, gallbladder probably mass can be present, sir.
What is it?
It's a mass in the gallbladder.
Yes, sir.
So you are thinking a carcinoma in the gallbladder.
Yes, sir. Yes, sir.
Can it produce ascites?
Yes, sir. In later stages, in advanced stages, it can produce ascites.
Garay, what is your sequence of symptoms?
So, okay.
Your sequence of symptoms is vague symptoms followed by jaundice. Okay.
And your
Sir,
gallbladder mass is producing obstructive jaundice. Don't
actually, to be very frank with you, gallbladder mass will not cause ascites that early. It is very late
sir, in advanced stages.
And you cannot salvage the patient if that is so. Okay.
Your case started with obstructive jaundice, your symptoms, and now suddenly you are putting. So there you have to be careful because in the end you are written as a lump or some mass in the gallbladder. It is so dilated or distended gallbladder you are feeling.
Yes, sir. Palpable gallbladder, sir.
Okay, go ahead.
Okay, how do you manage this patient now? Let's move. How do you manage this patient? You've come to your OPD, you've done everything. How do you manage the patient?
Sir, ultrasound whole abdomen was done for this patient.
Hang on. Just don't go to investigation straight away. Management means the patient has come to you, right?
Yes, sir.
You've admitted the patient. What are the things you do first?
First, we'll do after taking proper history and examination. Then I will perform certain investigations to confirm, support, and to treat the patient. And confirming.
Till then, you will leave him on the bed with pain and jaundice. Till his investigation.
No, sir. For the supportive management, if the patient is anemic, then we'll start for either.
If the patient is anemic, I'll start iron. What has got this iron got to do with this? How do you optimize your patient?
Sir, for anemia correction, we transfuse blood products.
You already said no pallor. For your patient, you said there is no pallor. You are confident that it is not anemic. Then you are talking about anemia, why? Sir, just now, sir said that you must talk in relation to your patient. How will you make for your own patient?
Sir, in this patient particularly, we have advised for hydration, adequate fluid intake either from oral intake or IV fluids. Then administration of vitamin K for 3 days, and then administration of broad spectrum antibiotics to prevent any sort of infection. Then for correction of adequate diets, high carbohydrate diet in these patients.
So it is hydration, infection, jaundice, nutrition, right? And coagulation.
Yes,
this is optimization.
Yes,
right. Now let's go to investigation.
Ultrasound whole abdomen for this patient was done. In the first ultrasound, in the liver, moderate intrahepatic biliary radicals dilatation was noted, and the gallbladder appeared grossly distended with multiple echogenic foci with posterior acoustic shadowing, largest measuring 1.02 centimeter, suggesting of cholelithiasis. And pancreas was found to be normal, and the rest structures was found to be normal. After the patient had a gradual progression of jaundice, the ultrasound whole abdomen was repeated, and it was found that the gallbladder was grossly distended with multiple foci, and with largest measuring 1.02 centimeter, suggested cholelithiasis, and a calculus of 13 mm was present in the CVD, with CVD diameter of 13.1 mm, and pancreas was found to be normal, and rest structures were found to be within normal limit.
So where is your malignancy?
So malignancy after in this patient, sir, after we have surprisingly having a CVD calculus, we went for MRCP, and it it showed that there was a mass in the neck of the gallbladders, in causing invasion to the adjacent structures.
You are expected to present clinical condition. So if you start presenting like that with a malignancy in this case, you can discuss on that. But your presentation should be what is you are seeing clinically. What is
right? You can't work backwards, right? In an exam, you can't work backwards. You can't just say in history is malignant obstructive jaundice because I got it on MRCP. First of all, MRCP is not the investigation choice for malignancy.
Yes.
Right.
Suppose this is the patient with this information is given to you. What makes you to suppose you suspect strongly malignancy and investigate? Suppose I ask you this question, what answer you will give in your patient, in particularly your patient?
So in this patient, after the initial ultrasound whole abdomen, if you are suspecting malignancy, then we'll go for contrast enhanced CCT abdomen, sir. Whole abdomen.
What I'm asking is, suppose I say with this finding,
yes, sir.
with this finding, I say it's a cholelithiasis, and I will ask, suppose you suspect cholelithiasis at this stage, what you will do?
Yes, sir.
What you will do? See the answer. They have given so beautifully gallbladder disease, calculus 13 mm present in the CBD, everything is there. And CBD diameter is 13.1 millimeter.
Yes, sir.
So, what you would have done?
So in this patient,
would you have done CT scan? That's what my question is. Or will you ask your gastroenterology person to do an endoscopy and take out the stones? That's what I wanted you to.
See, we'll do for ERCP and stenting, sir.
Please first, not clinical diagnosis based on that Courvoisier's law. Courvoisier's law is only, it has a lot of exceptions, then it has been actually been. Because you say it's a gallbladder is palpable, it could be a malignancy. That aspect also you should be very careful, because already here the CBD is fully blocked with the 13 millimeter calculi. So there may be no space for the bile to flow. Gallbladder will be distended.
Yes, sir.
And with this finding, even if a MRI shows you are MRI cannot show you a malignancy. MRI shows any stricture or anything. Also, it is doubtful. You need to further investigation to say it is a malignancy.
Yes.
Say very short duration, 8 days jaundice.
So what answer is what I wanted is what Professor Jailal has already told. High index of suspicion is, such a big palpable gallbladder, double impaction is theoretical, yes. But, it's very, very difficult to find such a big enlarged gallbladder in a only a stone disease. Correct?
Yes, sir.
So it's theoretical. So with that suspicion, definitely you have done. MR is better or CT scan is better? See, you said MR.
So in this particular patient, MRCP was done, but for if you want to rule out any gallbladder pathology, then we should go for.
Okay, why did you all go, Dr. Subrat? Why did you all go for an MRCP? Why did you go for an MRCP? What did you want to confirm?
Sir, any lower biliary tract pathology apart from the calculus which was being shown in the USG in the CBD?
What other calculus? What other pathology are you expecting for MRCP to show, which ultrasound is not showing?
Sir, any any periampullary carcinoma, sir.
So right, in this particular patient, what do you think is a better imaging, CT or MRCP? in this particular patient, after your clinical history and examination, what you have told, what do you think is the better modality, MRCP or CP?
Sir, the CCT abdomen would have been better, sir.
Dr. Garai, look, your ultrasound is telling us most of it.
Yes,
Right?
sir.
I mean,
Yes,
I
sir.
don't expect anything else which an MRCP would show. He's a young patient.
Yes, sir.
He's 36. I won't expect CA periamputary carcinomas in this age. Right?
Yes, sir. Yes, sir.
So, with this diagnosis,
Yes, sir.
the first thing which would come to us would be to go in for an ERCP. It is both
Yes, sir.
diagnostic and therapeutic. Why do you think
Yes, sir.
you have to do a CCT abdomen or an MRCP?
Sir, in case of in this particular case, it is palpable gallbladder along with jaundice patient. If there is mass present in the gallbladder,
No, if
or any
the ultrasound is showing that there is no mass in the gallbladder, I would expect that the ultrasound is proper, and it's not showing any
yes,
mass.
No,
so just to confirm my
all patients of obstructive jaundice with a dilated system, MRCP must be done. It gives you a
Yes.
roadmap also. That is what you should be able to say. And secondly, it's a non-invasive investigation that confirms it. And ERCP you will be needing, ERCP is nowadays reserved only for therapeutic reasons, which you would be
yes, ma'am.
needing in this particular case. So ERCP will be utilized only for reasons of therapeutic,
Therapeutic
not that you will
purpose.
be injecting a dye to be able to confirm, because that will have complications like cholangitis and all.
Yes, ma'am.
I hope do others agree with what I'm saying?
ERCP should be associated
Yes. It will
with
be therapeutic.
drainage. Yeah, ERCP alone never done. If you do
Yeah.
ERCP, drain the bile.
Yeah. It should be it should be done only for therapeutic reasons, not for diagnostic.
Okay, next slide.
Just to add on, sometimes MRCP will give you a level of obstruction. So it will suppose there is a type 2 non-communicating block, then probably you may not be able to do ERCP and
we can't hear you, sir. Sir, could you speak closer to the mic, please?
Yeah. I'm just saying that MRCP, if you do in such patient, not necessarily required in all, but that will give you an idea of the block. So many times a non-communicating block in which you may not be able to do an ERCP. So in those patients, you may plan based on MRCP to do a PTVD rather than a ERCP maybe. So that may give you
door-end stricture or something.
So that will give you some idea about that as well. Yeah, you can move ahead.
That is why MRCP is usually done.
Yeah.
As far as CBD stone is concerned, the MRCP is the investigation of choice. There's no doubt about that. If you are suspecting a pancreatic pathology, then CT is the investigation of choice. And as Dr. Ratna Chopra said that in this patient, it was ERCP is not an investigation here. It should be used only for the therapy purpose, not for the diagnosis purpose. So there is probably no harm in this patient to go for the MRCP, but Dr. Sai rightly said that ultrasound is giving everything, so you should go for the treatment. Does it require the MRCP in this patient or not? So you should have directly gone for the ERCP for the therapeutic purpose, not for the diagnostic purpose. But somehow when the MRCP was done in this patient, there was a different pathology which came out there.
Okay, next slide, please.
So MRCP was done for this patient, and it was found that a GB mass was infiltrating the caudate lobe, encasing the portal vessels, but not infiltrating the common hepatic duct, or along with lymphadenopathy. And common hepatic duct stricture with proximal dilatation of the biliary system was present. And after that, ERCP was done for this patient, in which there was a stricture present with proximal dilatation of biliary system and a 8 French plastic stent was present placed in the right system for palliation of jaundice.
So obviously
What about
ultrasound is absolutely wrong.
Then ultrasound is wrong, or no stone was there? ERC.
Sir, in ERCP, no stone was found, sir. And
So how did the ultrasound show a 13 mm stone? So either
It is a,
so
I think
ultrasound is. Do you have the picture of the ultrasound?
no, sir, I don't have that particular picture, sir.
So you should be able to answer that ultrasound is operator dependent. That is one. And there are some malignancies like cholangiocarcinomas which may be calcified and which may give an appearance of a calculus on ultrasound. I think Professor Dalvi has raised his hand, wants to say.
I think for the examiners, I think there is a point in getting endoscopic ultrasound into picture as an investigation here. Thank you.
Right. Okay. So the final court of appeal would be what now? ERCP showing something. No, hang on. MRCP is showing something. Ultrasound is showing something. So that's where Professor Dalvi said, now there's a dichotomy. There's a debate. So you should do an endoscopic ultrasound. Is it there or not there? Is there a role of endoscopic ultrasound? Yeah.
Sir, endoscopic ultrasound was not done, sir, for this patient, sir.
Okay. But would you have done?
Sir, we could have done that, sir, for the confirmation.
Do you have the films for MRCP and ERCP? I think you're showing it.
Sir, films. Yes, sir. Films of MRCP is present.
Yeah, let's see the film. Okay. The left one is your ERCP or MRCP.
So this
Sir,
shows a
both are
certain
MRCP
cutoff,
films.
no, at the level of.
Yeah, there's a cutoff there.
This shows a cutoff at the level of common hepatic duct.
Yes, ma'am.
There is no meniscus sign, which shows it is probably malignancy. And what you said, selective cannulation and stenting done, no? So what kind of stent was placed?
A plastic stent was placed, a short plastic stent.
Fine. Well, what would you expect? What kind of stent would you expect should be placed in a case of malignant jaundice?
Probably plastic stents would be better.
No, but that's not correct, no?
Why? Okay, why do you think a plastic stent is incorrect? Okay, let me put it. Why would a metallic stent be put? Or why is a metallic stent preferred?
Sir, metallic stent can have reactions.
No, so what you need to say is you need to put a covered, self-expanding metallic stent. Okay, so the complications of self-expanding stent would reduce, right? And you put a metallic self-expanding stent in those cases in which you want the stent to be there for a long period of time and you don't really want to remove it. And a covered stent would prevent complications, right?
Yes, ma'am.
I will just add one thing. Like in a patient, if you are in a malignant patient, if you are planning a curative treatment, be it periampullary, be it head of pancreas, or be it gallbladder also with obstructive jaundice. If you are planning a curative treatment later, probably it's better to put a plastic stent or a short SEMS. So, which can be removed during the curative surgery. So if you are planning a curative treatment, then you are right in putting a plastic stent or maybe a short SEMS can also work. But obviously, if you are thinking in a palliative treatment or advanced malignancy, but then probably a SAMS will be a better choice because it doesn't block easily.
It's an interesting case. No, you very specifically mentioned that portal vein is encased, but common hepatic duct is spared. Right? So what are you hinting at? You've not made a mention of any lymph nodes that are enlarged. And what about the hepatic artery and the common hepatic duct? So what are you trying to tell us by saying that there is encasement of portal vein, however, common hepatic duct is maintained and is not encased?
Yes, ma'am. According to the provisional discussion, the final report has not been published.
No.
Has not been
What
yet
is it? What is it that you're trying to analyze? Is this case an operable case or an inoperable case? So it's a locally advanced case for sure, right?
Yes, ma'am.
So would you
Yes,
want
ma'am.
to do surgery for therapeutic reasons in him?
Presently, we should not go for operate.
Why?
In this condition, there's encasement of the portal vessels, and
you are expecting this is a carcinoma arising from gallbladder or from the CBD?
sir, in this case, I'm suspecting of sir arising from gallbladders.
What is the reason for the stricture there?
So stricture, the mass was probably sir infiltrating in that particular
No,
locations.
no infiltration of common hepatic duct. That is what you are mentioned.
Yes, sir. Stricture can be an additional finding, sir, apart from the mass from the gallbladder.
So that is a benign stricture.
Yes, maybe probably.
Don't put too many things in the same thing. So one benign stricture, one stone, one malignancy, all the three were brought in now.
Dr. Gorai, I think this is a very difficult case, right? So you tell us basically now what is to be done. You've got a stone, the patient is having pain, he's having jaundice, and you've discovered a mass which is encasing the portal vessels, right?
Yes, sir.
So now what are the options which you have?
Sir, for initially palliative therapy, we can for relieving of the jaundice, we have gone for ERCP and stenting, and after an interval, we
Could
can
they remove the
think of
stone? Could they remove the stone during ERCP?
He said no stone.
No stone was.
Said
No stone was
obvious
retrieved.
defect. No stone
Yes,
was
sir.
seen. Okay.
Yes, sir.
Okay. And the stent was placed beyond the malignant portion?
Yes, sir, beyond the malignant portion. Yes.
Okay.
What do you mean by selective CBD cannulation?
Sir, portal vessels, so not sure about that, sir.
No, selective CBD cannulation. What do you mean by that? That's what I was asking you.
No, for your case,
what are the other ducts opening there? What are the other ducts
Sir,
opening?
Pancreatic ducts, sir.
Okay. So you right.
But carefully.
Okay, what about his stone? What will you do about his stone? Obviously, he's getting pain because of the stone.
Sir, after an interval, we can. So after optimizing the patient, we can plan for radical cholecystectomy, sir.
You go for radical? You just said the patient is
So cholecystectomy.
Cholecystectomy. Now it has gone up to the caudate lobe. That means it is a T4 lesion in the gallbladder.
Yes, sir.
So you are going to do a cholecystectomy for that.
Sir, after an interval, if the patient is jaundice is relieved and patient is symptomically improved.
Garai, you started very nicely. You said palliative care. Then why do you land yourself in trouble? Here is a patient, very unusually gallbladder masses are operable. I will tell you, very unusually gallbladder masses, because gallbladder masses, they grow very slowly, and when they are symptomatic, it's very advanced stage. Number one. Number two, you say portal vein is encased, you know.
Yes, sir.
So you rightly started saying that I will do palliative care and I will palliate the jaundice by stenting. That ends the
Yes, sir.
story. And if at all the patient is very young, patient is very fit, and the stenting is successful, then you can start some kind of palliative chemotherapy after obtaining a tissue diagnosis. That's all. Before trying to obtain a tissue diagnosis, you should ensure that there is no bleeding tendency. Okay. Beyond that, you should not stretch, otherwise you will be in trouble. Okay.
Yes, sir.
Should we call it a day, sir?
Yeah.
For the next.
So, but bit difficult case for the PG.
Yes, very difficult. Not for.
Things.
I have one question for the candidate.
Yes, sir.
Can you tell me one cause of non-obstructive jaundice which can be corrected surgically?
The non-obstructive jaundice, sir.
Non-obstructive jaundice which can be corrected surgically.
Patient may be associated.
Sometimes
if there is cirrhosis of
hemolytic anemias like spherocytosis will present to you with jaundice, and the patient will require a splenectomy. This is just an odd question I just wanted to bring in. Keep it in mind.
Yes, sir.
Okay? Yeah.
Okay, sir.
Thank you, Dr. Sai and other examiners.
Thank you, sir. Sir, Dr. Kanaval?
Yes, sir. Yes, sir. Yes, sir. 1 second, sir. There is some nuisance here. I need to remove someone. Sorry. I think Karai has been like bold to bring this case to this forum, and then I think he was able to withstand most of the questions. Appreciate that, Karai. But then, do you have any doubts or questions to be clarified with the eminent national faculty here?
Sir, regarding provisional diagnosis, sir, what should be the first diagnosis in this patient, sir?
What you admit, gallstones with obstructive jaundice. First diagnosis.
If you have to give also a differential diagnosis based on clinically later a palpable gallbladder, etc. Instead of trying to think in terms of double impaction choledocholitis, it should have gone more for a duodenal carcinoma rather than a periampullary carcinoma, for a simple reason that patient has no itching and no clay color stools, correct?
Yes, sir.
Correct. So you imagine ampullary and periampullary lesions, they present more often like that. So proximal, little bit of, proximal to the duodenal carcinomas there. So it's not that it's a must. Even a palpable gallbladder is not mandatory. But when it comes to that diagnosis, your diagnosis of malignancy here was based on palpable gallbladder, correct?
Yes, sir.
Correct, no? Irrespective.
Yes,
so palpable gallbladder with jaundice.
Yes, sir.
Hello. Yes.
So, yes, sir. Continue.
Hello. Yes. So that's what it is. So I think rest of the things have been, I think all have been clarified. The only problem is because you knew the full MRI, all the findings, you are probably trying to correlate that. So
yes, sir.
So otherwise, in the examination, you have a patient like this who has come with a jaundice, which is progressive dyspepsia. So because this patient has no clay color stools, patient has no itching, so that is the reason why you also will consider choledocholitis. You understand, no?
Yes.
You said he also has the pain there.
Yes, sir.
Dr. Gore, just to add on, if this is by patient, the first thing I think in history, I think the jaundice must have been for longer duration with such a disease. So I think you need to look into the history also. And also probably the first investigation in such patient will be a CCT abdomen, which will give us a fair idea that are we dealing with malignancy or a stone, and will give us more ideas about the stage also. So vessel encasement, any ascites, everything will be more clear with the CCT rather than subjecting him to so many investigations. So that will be our approach, I think.
Yes.
Abhay sir, I saw your hand going up. Anything you would like to add, sir?
Yeah, so let us examine this entire case in perspective. At the end of history, this man has nothing in his hand except jaundice. So at the end of the history, if somebody is asked, what is your diagnosis? I think he or she should stick to this patient has jaundice and he will require evaluation by examination and investigation. I think he has to stop there. There is nothing in his hand here at the end of history. At the end of examination, like Dr. Rajagopal Shenoy exactly said, he has a gallbladder, which is palpable. Now, when you have a gallbladder, which is palpable without any other things, the first thing that comes to mind is proper examination. You have come to a conclusion that this is gallbladder, which is non-tender. So the first things that should come to the mind is what are the causes of non-tender palpable gallbladder. The first thing that goes up is malignancy. Now, where is the malignancy is the thing to be seen later. But other causes of palpable gallbladder, which are non-malignant, is mucocele of the gallbladder. And also, mucocele of the gallbladder. So you have to differentiate between these two. Most probably, this is likely to be malignant. Now coming to a proper diagnosis and satisfying examiners, what is the level of obstruction is a difficult thing in this case. And for that, I would be with the student rather than, somebody who is trying to push him through. So all the best, dear this. Further investigations, again, he was in trouble. Ultrasound said stones. MRCP, luckily he did it and said there is a mass in the neck of the gallbladder. And CT scan also possibly said the same thing. I missed out on that. So it's a difficult case all in all to present at the level of the examiners. I'm quite sure examiners will be favorable to this candidate. Thank you, Kanagwal.
Thank you, sir. Kanna sir, any comments, sir?
Whenever you get a case of obstructive jaundice or a jaundice along with a palpable gallbladder, we must not forget that there is a palpable gallbladder with the jaundice is there, even if the patient did not have the itching or the clay-colored stool, but the patient had the jaundice. So once you get this combination is there, then the first thing which comes in your mind, are we dealing with a case of carcinoma head of pancreas? Or we are dealing with a case of periampullary carcinoma? Or we are dealing with a case of cholangiocarcinoma below the opening of the cystic duct? Or are we dealing with a case of a carcinoma neck of the gallbladder? We get a lot of the cases of the carcinoma neck of gallbladder, which presents as just like this patient as a mucocele of the gallbladder. But the pathology there is in the neck of the gallbladder. So I think probably if you overall sum about this case, then this patient is having a carcinoma on the neck of the gallbladder, which is infiltrating into the common hepatic duct. Though he has written in the MRCP that it is not infiltrating, but it is infiltrating in that. Along with the infiltration of the portal vein surrounding is there. So it is almost becoming an inoperable case for the definitive treatment. So the treatment in this patient is only palliative treatment. So here I will go with this order that the first diagnosis should be carcinoma of the pancreas. Second is a periampullary carcinoma, the cholangiocarcinoma. Third is a carcinoma neck of the gallbladder. So these will be the three differential diagnoses in my list. And sometimes choledocholithiasis, it is exceptionally that there's a choledocholithiasis is there. But in the choledocholithiasis, you do not get such a distended gallbladder until there's a single impaction of the stone at the ampulla of the water or the double impaction of stone at the neck of the gallbladder and the ampulla of the water.
Okay, not bad. I will take that. I want that skin really badly.
Okay.
Two.
Actually, sir, I agree with you, but the pain is his presenting symptom. So
That's
that
one.
is why I was putting up the stone at a higher point.
Fine. It's okay.
You're right, sir, that there can be stone because of that, but usually that Carvoiser's law
Right.
in this is not correct. Yeah.
Right.
Right.
Here we go, boys. Come on. Oh.
Okay,
Okay.
Dr.
45 for the SpongeBob. Legendary. Okay. So that completes the first case session. Thank you, Dr. Garai, for joining us.
Thank you.
If you could stay here for the second case discussion, please unshare your PowerPoint.
Yes.
Dr. Velumani, are you with us?
Yes, sir.
Okay, Dr. Velumani is from AIMS Rishikesh, kindly contributed by Dr. Amit Gupta. She is here to present a case of a soft tissue tumor of the limb. Dr. Yogapriya, please introduce yourself, your unit chief, head of the department, and start your presentation. Faculty, please take over. Good luck to you, Dr. Velumani.
Thank you, sir. Good evening, respected faculty. I'm Dr. Yogapriya Vedamani, junior resident from Department of General Surgery in AIMS Rishikesh, under the guidance my moderator, Professor Amit Gupta, sir, Dr. Deepak Rajput, sir, and head of the department, Professor Som Prakash Basu, sir. I'm here to present a clinical case presentation on soft tissue tumor. History: a 28-year-old gentleman, student, resident of Bijnor from UP. He presented with the chief complaint of swelling in the left leg for the past 1 year. History of presenting illness: the patient was apparently well 1 year ago, after when he noticed a swelling in the upper inner aspect of middle third of left leg, which was insidious in onset. It was gradually increasing in size from initial size of 1 × 1 centimeter to the current size of approximately 9 × 6 centimeter. It was not associated with pain or fever. There was no associated overlying skin redness, ulceration, or discharge. There was no associated with restriction of movement in left leg, no history of any other similar swelling elsewhere in the body, no history of trauma to the affected site, no history of any radiation exposure or chemical exposure, no history of numbness or paresthesia, edema, weakness in the limb, no history of groin swellings, no history of unconsciousness, headache, seizure episodes, or blurring of vision, no history of any shortness of breath or cough or hemoptysis or chest pain, no history of loss of appetite and weight, and no complaints in the opposite limb. Past history: there was no history of similar swellings in the past. Patient has no known comorbidities. There is no history of any past surgical intervention. Coming to the family history, there was no history of any malignancy or similar swellings in the family. Personal history: the patient takes a mixed diet. Appetite was normal. He's a non-smoker. Occasional consumption of alcohol was present. The sleep pattern was normal, and the bowel habits were normal. Summarizing my history: a 28-year-old gentleman with no comorbidities presented with a painless swelling in the left leg for the duration of 1 year, which was gradually increasing in size from an initial size of 1 × 1 centimeter to the current size of approximately 9 × 6 centimeter. It was not associated with any pain or fever, and the history was not suggestive of any distal neurovascular deficit.
What do you think with history?
The patient is,
what do you think with history?
Yes, sir. The patient is having a rapidly growing swelling, sir, which is also painless and in the extremity, and there is no complaints of any fever or pain. So I would think of a soft tissue swelling, sir, since it's in the extremity also.
Is it rapidly growing? I mean, over a period of 1 year?
I'm not able to hear you. What is your diagnosis, Yogapriya?
So I said it could be a soft tissue
What is your
swelling.
diagnosis? What is the conclusion?
I came to a conclusion of soft tissue swelling or soft tissue tumor, sir.
Why not bone? You're not
It
examined,
could be,
you know.
sir. Yes, sir. I haven't examined.
Then so with this history, you can say that a young gentleman is having probably a musculoskeletal tumor.
Okay, sir.
Okay.
Okay.
Do you think it is benign?
Could be, sir.
Do you think it is benign or inflammatory?
But there is no signs of
What is the
history of
suggestion
inflammation.
in the history?
There is no pain, there is no fever.
No pain, no inflammation, no fever, just swelling, no limitation of movement. Why do you think it could be either benign or malignant? Considering the short history, you can consider malignancy,
Yes,
but
sir.
it cannot be inflammatory or infective, you know.
Yes, sir, because there
Okay.
is no pain or fever, sir.
My job is over.
What is the occupation of this patient?
So he's a student, sir.
Should we go to the examination, sir? Okay, Dr. Velamani,
Yes, sir.
examination, please.
Yes, sir. On general physical examination, the patient is conscious, oriented to time, place, and person. Is moderately built, well nourished, and adequate hydration. Vitally, the temperature was afebrile, pulse rate of 96 minutes in the right radial artery, blood pressure of 106/72 millimeter mercury in the supine position in the right arm, respiratory rate of 18 per minute, and a saturation of 98% on room air. Height was 149 centimeter, weight of 51 with a BMI of 23 kg, and ECOG was 1. There was no pallor, no icterus, no cyanosis, no clubbing, edema, or generalized lymphadenopathy. On inspection, the gait of the patient was normal. The right lower limb appears unremarkable. A swelling of size approximately 9 cross 6 centimeter is present on the left upper leg in the middle third. The superior border of the swelling is approximately 8 centimeter from the medial tibial condyle, and inferior margin is 15 centimeter from the medial malleolus of the ankle, and the medial border of the swelling is 2 centimeter medial to the shaft of tibia. It is ovoid in shape, and the surface appears to be lobulated. It had well-defined margins. No visible pulsation was seen. Overlying skin appears normal with prominent vein and with no air loss. Swelling appears prominent on plantar flexion of ankle. There is no edema in affected limb and wasting of distal muscles of lower limb. No pigmentation, sinus or scars, and no visible swellings in the groin. This is the image of the patient. Proceeding with the palpation. There is no rise, no local rise of temperature, non-tender. The inspector findings are confirmed. Lobulated surface and firm in consistency, and the swelling had well-defined margins. It was non-pulsatile and it is not fixed to the overlying skin. It's mobile in both direction in the relaxed position and restricted mobility on plantar flexion at the left ankle joint. No regional lymphadenopathy were present, and the girth was 27 centimeter on the left side and 21 centimeter on right side measured in the mid-calf. Sensory and motor system examination were unremarkable in both the limbs. Peripheral pulses were not palpable in both the limbs. So. Systemic examination, cardiovascular system, normal S1, S2 was audible and no added sound. CNS, no focal neurological deficit.
Naturally, other system examination will be normal.
Yes, sir.
Okay. What is your diagnosis?
So, a 28-year-old gentleman with no comorbidities presented with a painless swelling in the left leg for 1 year, which was gradually increasing in size from initial size of 1 cross 1 centimeter to the current size of approximately 9 cross centimeter. It is not associated with pain, fever, with no history suggestive of distal neurovascular deficit. On examination, it is a lobulated surface, firm in consistency, with restricted mobility on plantar flexion, with no inflammatory signs and no sensory or motor deficit in affected limb.
Dr. Velumani, there are two things. First, I'm not being able to place where the swelling is. Left leg where? Medial, lateral, anterior, posterior where?
Upper inner aspect of the left leg, sir. Medial compartment.
No, after examination, you tell whether it is from posterior compartment, anterior compartment, or peroneal compartment. It is okay. If it is history, okay. You have now completed the examination. As a medical student, now you should be able to say whether the mass is from bone or soft tissue, number one. Number two, whether it is which compartment is from, peroneal compartment or anterior compartment or posterior.
Okay, sir. So it is probably a soft tissue sarcoma arising on the medial aspect of the left lower leg, sir. Middle
Which
third of the
compartment?
medial.
Peroneal compartment, is it?
Sir?
Which compartment?
Medial, sir. Medial aspect of the
Which
leg.
compartment? Medial means which compartment?
Okay, what are the compartments of the leg? How many compartments are there in the leg?
I have anterior, posterior, and lateral compartments, sir.
Is that? That's it. Anterior, posterior, lateral.
And medial.
And medial.
Do you think it's different in thigh and different in leg, or it's same everywhere?
In thigh also, we have anterior compartment muscles, posterior medial compartment.
Okay. There are 4 compartments, right?
Yes, sir.
You have the medial, you have the lateral and posterior, you have 2, superficial and deep.
Superficial and deep.
Okay. Now tell me, what are the structures in each compartment? Which muscle do you think is it rising from?
On the anterior compartment, we'll have tibialis anterior, external ilicis longus, and laterally all the peroneal muscles will be there, sir. Posteriorly, we can see the gastrocnemius soleus.
Able to hear you.
No, is it in the anterior compartment?
It is most often the posterior compartment, sir.
So why are you telling me the muscles of anterior compartment? I asked you from which muscle is this arising?
Posterior compartment, mostly gastrocnemius soleus muscles are present, sir.
That's it.
Tibialis posterior.
Why don't you say it is arising from calf muscles?
Yes, sir.
Okay.
Okay. So the superficial compartment consists of gastrocnemius and soleus, right? Okay. Also, is the swelling compressible?
No, sir.
You've not mentioned it. Is it
Okay,
compressible?
sir. No, sir, it is not compressible.
Why do you think this is important?
If it is any abscess or any vascular swelling, it could be compressible, sir.
Right. Okay. Sir, please.
You have examined lymph nodes in this patient. So what are the group of lymph nodes you have examined, and when do you suspect lymph node metastasis in a STS, soft tissue sarcoma, if you are thinking in that line? Do you think STS metastasized to lymph nodes?
The percentage of lymph node metastasis is less, sir. But if I would to examine in this patient, I would examine for the popliteal as well as the inguinal nodes, sir.
So what are the STS which metastasize to lymph nodes, soft tissue sarcomas?
Would be rhabdomyosarcoma, sir. Angiosarcomas, clear cell sarcomas, synovial sarcomas, sir.
Okay. Okay, fine.
Okay, Dr. Velumani.
Yes, sir.
Now you said that the thing becomes more prominent on plantar flexion of the left ankle joint, isn't
Yes,
it?
sir.
So which muscles are involved in this plantar flexion of the
So the posterior compartment muscles will be involved in the
Which
plantar
muscles?
flexion.
Which muscles?
And I would say gastrocnemius,
Gastrocnemius
soleus,
and
epiphyseal, posterior.
and plantaris. So which nerve is involved? Which nerve is involved in this action? Because you got to test this nerve. Which nerve would be involved? Which nerve causes this plantar-flexion? The posterior compartment. So which is the nerve of the posterior compartment? Dr. Velumani, it's tibial nerve. Look.
Yes.
Look. We are dealing with a soft tissue tumor of the leg, the posterior compartment. At least read what this whole thing is all about.
Yes, sir.
Right? You've not come prepared, because look, you got to remove those muscles of that compartment.
I'm not able to hear you.
You got to remove. The thing is surgery. You got to remove the muscles of that compartment.
Yes, sir.
Now, if you don't know which muscles are there, how will you go and do it? Okay. Yeah.
So you're looking that the girth 27 centimeter on the left side and 21 centimeter on the right side, correct?
Yes, sir.
So when do you do this test actually? What is the significance of this measuring the girth?
If I were to look for any atrophy of muscles, sir.
Normally we don't do it if there's a swelling like that. You understand? The girth measurement happens if there's a local gigantism or whether the muscle has become atrophic. So you understand, no? When we say local gigantism means the part which is locally enlarged uniformly. Do you know some examples for that, like local gigantism?
Lymphatic.
This is not an example for a local gigantism. This is for your information. There is a swelling. You are having the tape over the swelling, correct?
Yes, sir.
So that naturally it will be more. So that is not required. What I'm trying to tell is this swelling, you have to give a dimensions of vertical and horizontal, correct?
Okay.
Rather longitudinal direction. Yeah, show that picture. Yes, correct. So the issue of the issue of girth will not come here much, because you are going to give a measurement of longitudinally measuring about horizontally. Okay, and then comes the shape you have mentioned. The margin rather border is better. You say firm lobulated swelling, correct? Hello?
Hello, sir. Yes, sir.
You have written lobulated and firm swelling, correct?
Yes, sir.
So what do you mean by that lobulation? Since you use the word lobulation, are you hinting at lipoma or something like that? Or what is that you want to say?
So it had a bossulated surface. Like if it had been a cyst or something else, the surface would have been smooth, sir.
No, we are not considering cyst at all here, because you have mentioned from the beginning that soft tissue, that's
lipoma also might have a smooth swelling.
What is the sign you elicit in a cyst? Clinical examination? Fluctuation.
Correct.
What is the fluctuation you have in lipoma?
Slip sign, sir. It will slip. The margins will slip away from our palpating fingers.
Is it pseudo fluctuation?
Yes.
Can you have pseudo fluctuation in lipoma?
Yes, sir. Since it's not a cystic swelling.
So it is not fluctuant, So you should not say cyst. Okay.
So did you mention about limb above, limb below?
About the extent, sir?
So, yeah, correct. Any veins he has got? Prominent veins because of this large swelling? Any compression on the long saphenous vein?
No, sir.
Any dilated veins in the leg? Secondary
No, sir.
varicosity. Secondary varicosity, right? That you have to look
Yes.
for. Tomorrow,
Okay,
if
sir.
somebody comes in a small thin veins or medial side, you should not. So you should always suspect some problem above also, right? So look for the veins you have written, and also pulsations, right?
Yes, sir.
Knee joint is normal.
Pardon?
Knee joint.
Yes, sir. It's normal, sir.
Why did
Dr.
you mention
Velumani,
so
Dr.
many
Velumani,
things? Why did you
Yes,
mention
sir.
so many things in the abdomen? Like, see, unnecessarily that is not required. So let's slide on the abdomen. Soft tissue. If you have diagnosis of soft tissue sarcoma, does it go like this? No, not necessarily all this, so many things. Hernial orifices. Unnecessarily should not get into trouble in the exam. Just for you. What you have to relevant things only, you should concentrate. Sensations. Have you checked for sensations?
Yes, sir. I have done that, sir.
So because where you have mentioned sensory system, now okay, written sensory system. What we would like to know is a local. Local means distal neurological, effects. Whichever nerve, if it is there, sensory deficit. Okay. Go to the diagnosis, sir. Anyone, please, sir.
Dr. Velumani, I'll tell
Yes,
you
sir.
what. You have a case of soft tissue sarcoma, right? Or a soft tissue tumor. You have to examine the limb in toto, the movement of the range of joint movement, the range of movement of each joint, especially the knee and the ankle. You got to particularly mention about, because it's the posterior compartment and the tibial nerve, you must mention whether the tibial nerve is involved or not, right? Whether there is any bony involvement or not, whether there is an arterial involvement or not, which muscles are being involved, which compartment is being involved, right? So it has to be more specific once you know that you're dealing with a tumor of
Okay,
the
sir.
posterior compartment.
What is the artery you will feel to rule out arterial involvement in this patient?
Popliteal artery will be there, and then it divides into tibial arteries, anterior and
No,
common.
I am clearly
posterior
asking
tibial.
to rule out arterial involvement.
Posterior
Which
tibial.
okay.
So how will you test for the sensory portion of the tibial nerve? Where did you test for it?
So for sensory, I test the fine and crude touch on the dermatome level, sir, in the posterior compartment.
Okay, what posterior tibial? Where do you test?
Posterior aspect of the leg.
Posterior aspect of the
Leg, sir.
leg. That's it.
And sole.
Where sole? Which portion?
And
okay. Look, you'll have to go and read about it.
Okay, sir.
Tibial nerve has got both sensory and motor.
Yes, sir.
The motor we've discussed is the posterior compartment, right? The muscles, the deep muscles are involved in the movement of the ankle joint, lateral and all those rotation. And the superficial compartment is involved with the plantar flexion, which you correctly said. The nerve involves most of the posterior portion of the posterior and lateral portion of the sole, isn't it? So how can you if you don't know the sensory distribution, how can you test it? Right? Go on. Okay, so how will you manage this patient now?
So I would like to go for a radiological investigation first. And since it's an extremity swelling, I would suggest go for an MRI for the patient, sir. And then following that, I would like to go for a core needle biopsy.
You wouldn't like to take an X-ray, plain X-ray of the foot?
Yes,
of the
sir.
leg?
Plain radiographs to see where the swelling is arising from, sir, if it is any bony swelling or not.
Right. So always take a plain X-ray first.
Okay.
Right? Okay. Then you've gone in for an MRI.
Yes, sir.
Okay, why do you want to get an MRI done? What will it tell you?
Since it is a soft tissue swelling, we'll get to know
What are you looking
better
for
the
in an
MRI.
MRI? Okay, what are you looking for in an MRI?
So the anatomic site, and then is there any adjacent structures involved, sir?
What site? What site are you looking for? What is particularly about the site? Site of the you can see that is on the posterior aspect, posterior lateral aspect, or in a posterior medial aspect of the leg. Its site is So why do you want to get MRI done?
Involvement of adjacent structures, sir?
Which adjacent structures?
Any neurovascular involvement is there or
That
not?
you can feel. You said palpation, but pulses are normal. The nerve is not involved. So why do you want an MRI? Look, for an MRI, you want to know which muscle compartment. You can't just, you want to confirm your findings. So which muscle compartment is involved? Is the nerve involved? Is the artery involved? Is the vein involved? Is it on the, is the periosteum involved? Right? So all this you'll have to know. That's why you get an MRI done. Do you have the MR films?
So unfortunately, I couldn't get the radiological investigation film, sir.
Okay. Okay, you've got your MRI done. What did the MRI say?
So we couldn't get the investigations done for this patient itself.
Okay, okay.
I don't have the investigations.
Okay, so you got an MR done. Okay. Now
Why do you
MR
want to
says,
do, why do you want to do MRI before biopsy? Any particular reason?
So the swelling might have an anatomical distortion if we go for any interventional procedure before radiological, sir.
what anatomical distortion can cause a needle cause in a patient of this?
Since we are going for a core needle biopsy,
What
we don't know
distortion
what.
can it cause?
For that, you have to know what are the principle of doing a biopsy in these soft tissue sarcomas. How will you approach?
Yes, sir.
So MRI probably give you the most probable location from where you should get the biopsy. So these tumors, there may be cystic areas, there may be some hemorrhagic areas, there may be necrosis, there may be solid areas, right? So MRI will probably give you the best place from where you can get your tissue diagnosis. Also, you should know that soft tissue sarcomas, you have to stick with principle from where to take the biopsy. So your biopsy track should be the shortest route first, so that you don't contaminate other compartments of the leg, right? Also, it should be the through a track which will be incorporated in your final excision. So that principle you have to always follow. So MRI first, because you need to follow the best, you need to know the best way to do a biopsy probably, right? Other than what other things we discussed, yeah.
Okay. So look, you usually don't do a core biopsy because of if there's hemorrhage, right? That's why it will not distort the anatomy. Okay, there'll be hemorrhage, and then your this findings can be confounded. Okay, so you've done a core biopsy?
So the
Will you
patient
do a
was
core
not.
biopsy or will you do an open biopsy? Let's come to that.
I would do a core needle biopsy only, sir.
You'll do a?
Core needle biopsy.
Okay. Why not an open biopsy?
So the incisional biopsy, if we do the patient, if we are not planning well for the incision where it to be placed, or it might end up having a tumor seeding, or the wound might have hemorrhage, infection.
You think tumor seeding cannot happen with a core biopsy, or hemorrhage cannot happen with that?
It can happen, sir, but
Okay, so what are the indications for an open biopsy now? Let's come to that.
So if in the core needle biopsy we are not able to conclude a diagnosis of what subtype it could be, or if it is not giving a diagnosis for us, we could proceed with an incisional biopsy, sir.
Or the skin is already involved. Okay. Right? Okay. So what are you looking for? Is an incisional biopsy better than a corneal biopsy?
Incisional biopsy, the amount of tissue we might excise could give us an insight of what kind of a subtype sub, but on patient, based on the patient basis, a corneal biopsy would be better to
No,
avoid.
an incisional biopsy is always better than a corneal biopsy. It is just that a corneal biopsy is usually adequate, but if you have an option of the two, incisional biopsy is always a better. It gives you a better tissue sampling, right? So what are you looking for in your biopsy now?
What is that? What is the advantage of corneal biopsy?
It's a less invasive procedure, sir. And
It's an office procedure. Patient need not get admitted.
Yes, sir.
You don't require the operation theater, and probably you may not require anesthesia also. Cost effective, and most of the time it will reveal whatever information you want to know. That is type of tumor and grade of the sarcoma. Okay. But
It's the first acceptable diagnostic step. It is the first acceptable diagnostic step. That's what about FNAC?
FNAC won't give you an adequate
No,
tissue.
in other way, sir is asking, what is the indication of FNAC in soft tissue tumors or soft tissue sarcomas?
Maybe if the swelling is of a smaller size, sir.
No. The answer should be, if it is a recurrent tumor, to prove recurrence, or if it's a metastatic lesion, to prove metastasis, you can do FNAC. But with FNAC, you may not subtype the lesion and you may not give the grade also. Okay. To diagnose recurrence and to confirm metastasis, you can do FNAC. But primary diagnosis is by Tucker biopsy, because you need to grade the lesion and you need to do subtyping also. Unfortunately, soft tissue sarcomas are the incidence is very less, but subtypes of numerous, even oncologists are confused.
No, to add on that, WHO classification has more than 120 variants of soft tissue sarcomas. So and each of them behaves differently clinically and prognosis wise also. So they have clubbed as a soft tissue sarcoma, but they all behave very much differently among themselves. So
do you know a study conducted in Europe where they asked to same slide, they gave to 100 pathologists, and do you know what was the discordance of the subtyping and grading percentage? 20%. Okay, even pathologists are confused.
Okay, so one is diagnosis of the tissue. Second is assessment of the extent of the tumor, right? So your investigation will move first to prove the diagnosis, then second would be assessment of extent of tumor. So how do you do that? What is the role of CT scan?
So if CT scan would I would like to do a CT scan in case of this for look for metastasis, sir. And if it's also
Just for metastasis?
yes, sir. And if there are CT abdomen to look for any other lesions, retroperitoneal.
Okay. So if CT with contrast, especially when on MRI your tumor is isodense with the vascular or it's a highly vascularized tumor, right? Then you'll have to do a CCT. Okay. Bone involvement or highly vascular tumors, right? Then you got to get a CCT done. Okay. Then you have to do assessment for metastasis. So how do you do that?
CT chest, I would look for, sir, and CCT abdomen.
Sorry. Before that, any role of CT angio?
For vascularity, yes, sir.
No, vascularity. What do you mean by vascularity?
But if the MRI shows any involvement of vascular structures, sir,
What kind
I
of
would like
involvement are you looking for?
I would like to know the.
Do MRI angiogram. Why do you want to do CT angiogram?
Sure of that.
So in this patient, there is no role for CT angiogram because in leg, there are 3 blood vessels are there, Sacrificing one is not going to harm the patient. Okay. And
Right.
most of the soft tissue
Okay.
soft tissue sarcomas are pushing, not infiltrating. It is very unusual to find a soft tissue sarcoma involving the neurovascular pedicle. The neurovascular pedicle may be surrounded with the tumor, but usually it will not be infiltrated with the tumor. And very rarely we find soft tissue sarcomas where there is neurological deficit. Vascular compression may be there, venous compression may be there. It is very rare to find the soft tissue sarcoma involving artery and nerve.
Okay, now let's come to the question: which soft tissue sarcomas can involve the nerve, and which can involve the vessel?
Angiosarcomas.
If it is arising from nerve and vessel, simple,
Right.
Yes, sir.
So, which is the commonest sarcoma arising from the nerve? We can't hear you, Dr. Velmani. I think we've lost her.
Sir, I think she's with us, sir. Velumani, please check your mic, ma. We are unable to hear you. I think you swapped this. Yeah, now it is better.
Are you there, Dr. Velumani?
Yes, sir.
Please
Hello.
with us, sir. Switch on your
Hello?
video, man.
Yes, sir.
We are able to hear you, but in between we lost your audio, man.
1 second, sir.
You can expect this investigation.
Okay, Dr. Velmani, are you there?
Allow her a minute, sir. I think she's swapping the mic or something.
Sir, most of the discussion. Sir,
Yes,
most of the discussion is has been done. I think we can conclude with.
One moment, sir. Let her come back, sir. I think she's with us, sir. Allow a couple of minutes, sir. I think we can quickly cover the management part and close it, sir.
Yes. I would like to know the staging and the management.
Yoga Priya, are you okay, ma?
Hello. Hello, sir.
Yes, ma. Yeah, please switch on your video. I think we are perfectly
Yes,
able
sir.
to hear you. Please
Hello,
go ahead.
sir. Yes, sir.
Faculty, please take over.
Okay, what's the stage of your tumor then?
So it's depending on the size alone, it's T2, sir. Stage I can't give because I haven't done a histological evaluation for the patient, sir. Grading of the tumor is not.
Okay.
Grading of the tumor.
Okay. So it is T2.
T2, sir. But grading is not
What's the size of your
available.
tumor?
9 cross 6 centimeters, sir.
9.6. Okay. And what about nodes?
No peripheral, no lymphadenopathy was present for the patient, sir.
Okay. No mets and grading, you don't know.
Yes.
Okay. So how is the grading done?
Histological grading of the
Yeah, how is it done? What is taken into account? What are the factors taken into account for grading?
mitosis, the
Okay.
number of depth involving, sir, and the mitosis will be taken, and cell
So there are three things, right?
aggressiveness of the
No. Don't keep on saying if you don't know. Differentiation, mitotic count, and necrosis. So there's necrosis score, there's mitotic count, and there is total differentiation. Right? This is what the grading depends on. Okay. Okay. So how will you manage now?
after the investigations, I would go for a wide local excision of the tumor, sir.
Okay. What is wide local excision?
So I would leave a margin of 2 centimeter, 1 to 2 centimeter of the
1 to 2 centimeters is wide local excision.
more than 2 centimeter margin. I would leave and excise the mass, sir.
It is 5 centimeters. Wide local excision in sarcomas is 5 centimeters. Right? And radical excision is greater than 5 centimeters. Correct me if I am wrong. I think that's it.
So, what is the principle of excision in soft tissue sarcoma? Means on table you can't measure with the scale, right? You can't measure with the scale with your margin. So what is the principle? How do you know that you are well above, your margins are clear surgically when you are operating a soft tissue sarcoma? What is the principle you follow? Do you measure it's 4 centimeter, 5 centimeter, or you follow something, some anatomical landmark or some indication? So what we usually follow in soft tissue sarcoma excision is you have to leave one uninvolved anatomical structure over the soft tissue sarcoma. So suppose you have to leave one uninvolved muscle ideally, or maybe uninvolved fascia, which is grossly uninvolved intraoperatively. By doing that, you are pretty sure that your margins will be clear because you can't measure it with the scale, right? So that is what is followed in cancer surgery.
Or the tumor should not be visible at all during surgery. You get me?
Yes, sir.
So management of soft tissue sarcomas is multidisciplinary,
Yes,
and it
multimodal
depends on whether it is round cell sarcoma or spindle cell sarcoma. Even in spindle cell sarcoma, if it is high grade like synovial sarcoma, we are justified in giving preoperative chemotherapy. Particularly in this patient, since the patient is young, there is a possibility that the sarcoma may be extraskeletal leavings or PNET. So you should be knowing the grading and subtyping. At least from a surgeon's point of view, you should know whether it is round cell sarcoma or spindle cell sarcoma. Spindle cell sarcomas are usually treated with surgery, and surgical clearance is 2 centimeter all around. If you want, you can have a frozen section control. And always a tough fascia like periosteum or adventitia is considered 2 centimeter, even though technically it may not measure 2 centimeter. You can consider tough fascia like deep fascia or periosteum or perineurium or adventitia as 2 centimeter. And the most radical excision is amputation, which we don't know nowadays. Less than that, you can go for compartmental excision if there are definitive compartments where the muscles are removed from margin to incision, particularly for low-grade sarcomas, where the lesion is in the middle of the compartment. And adjuvant is always necessary. This size, even if it is low grade, probably the patient may require adjuvant radiation. While giving adjuvant radiation, you should take care that you should not include the 360 degree of limb. If you give radiation 360 degree, it will amount to compartment syndrome. So patient will go for compartment syndrome because of fibrosis. These are all the points you should remember in sarcoma. And in MS level, I think it is very far-fetched, and even the MCH level, many are not comfortable because they are not managing musculoskeletal tumors. I leave it to the other examiners.
Yeah. So just to add on, this is soft tissue sarcoma, as we discussed. It's very varied tumor. So for management, surgery is the mainstay always. But there are and round cell tumors, we don't treat them as a soft tissue sarcomas. They are a different entity because they are very responsive to chemotherapy like Ewing's and rhabdomyosarcoma. So in those cases, we always give induction chemotherapy, then we operate, and then we give maintenance chemotherapy. But for most of the soft tissue sarcomas, surgery is the mainstay whenever it's operable. And as we discussed, we follow that we leave one uninvolved anatomical structure above the tumor. There are few sarcomas which are chemosensitive. They are not very chemosensitive. They are, you can say, moderate. Sometimes they respond, sometimes they don't. So the response rate is in the percentage of around 30 to 40%, not more than that. So they may get shrink with chemotherapy, like synovial sarcomas, and sarcomas what we call as L sarcomas, like leiomyosarcomas. So there are few sarcomas which respond sometimes to chemotherapy, they shrink, and then we can probably remove them with a negative margin. So still surgery is the mainstay, and post-op radiation, or what we call as adjuvant radiation, is required in if size is more than 5 centimeter or it's a high grade. So the most important prognostic factor in a soft tissue sarcoma is grade and followed by size. So that is all I think you need to know at this level.
So I think she should be able to talk about reconstruction and rehabilitation after.
That will
Reconstruction of the defect and rehabilitation subsequent to surgery.
So you want me to speak on this one? Or, yeah. So reconstruction usually, again, you have to see that it's a soft tissue sarcoma or it a bone, what we call as osteosarcoma, bony sarcomas. So now with bony sarcomas also we are doing what we call as limb sparing surgery. So we have lot of prosthesis, different type of prosthesis. We have prosthesis actually which we can, especially in children, we can adjust them as per their growth. So every year we can just increase their length little bit so that both the limbs are in the equal with their growth. Also in soft tissue sarcomas, most of the reconstruction options are basically either a localized flap if the defect is large, or sometimes you can use free flaps also. Also, the anatomical location will actually decide what kind of reconstruction you are planning. So for probably limb sarcomas with such a big defect, if like it's a big defect, then most of the time we use free flaps. For trunk sarcomas, most of the time you can use localized flaps like latissimus dorsi flap for trunk, or sometimes in hand and all we use a groin flap also you can use if there is no option of free flap. So there are multiple options depending on the anatomical location and extent of the defect actually. Plus again, rehabilitation is a very long process in this soft tissue sarcomas and bony sarcomas. Especially with the prosthesis, we need to teach the kid, or usually they are younger people with osteosarcomas and all. So they need a very long rehabilitation. And with the kind of prosthesis we have, many children, after the treatment, they are still running actually, not walking, but they are running. So the technology has progressed to that we can offer them a very good limb sparing surgery now.
Thank you, sir.
Professor Kanaval. Sir. Okay, I think we can call it a day. Dr. Velumani.
Yes, sir.
All right. Do you have any questions?
No, sir.
Professor Dalvi, are you there? I think he's left. Professor Khanna? Sir? I think they've left.
Subhay sir is also there, and I think should we allow the student Yoga Priya? Do you have any questions to ask before closing? Faculty, Mayank sir, Shubhaya sir, Kanna sir, Ratna ma'am, can we call a closer, Sahay sir?
Yes, sir.
I'd just like to tell her, Dr.
Yes, sir,
Yoga
please,
Priya,
sir.
Yes, sir.
look, your discussion will not go up to so much. Your basics have to be strong, right? So when your examination, the muscles, the compartments, the nerves, the blood vessels, right? You should know, because lymph surgeons don't usually manage. So this is in the back, it's always in the back burner, right? But when you're presenting a case, at least you should revise it and come.
Else, sir? Subhay sir?
Thank you, Ganagavel. Thank you, Ganagavel.
Thank
It was
you,
a
sir.
very good discussion.
Thank you,
Thank
sir.
you for
Thank you.
joining. Mayank sir, thank you very much. Other senior faculty, Karnakaran sir, Ratna ma'am, thank you very much. Thank you, Yoga Priya and Gabar, for
Thank you, sir.
joining us this evening. Sudhabrata Gabar, if I'm Garai, sorry. And thanks all the faculty for kindly staying with us till late night. We wish you all a very happy Diwali and Dantiras for the coming week. And we look forward for coming Friday for next PG clinics. Thank you very much.
Thank you.
Happy Diwali, sir. Happy Diwali.
Thank you, ma'am. Thank you.
Happy Diwali, sir. This is Ambujam.